Hi, everybody. I'm Shahn Amdani. I'm a pediatric cardiomyopathy, heart failure, and transplant cardiologist at Cleveland Clinic Children's. And I'm here to talk about the American Heart Association scientific statement that is looking at evaluation and management of chronic heart failure in children and adolescents with congenital heart disease. This is an important statement because as a community, we recognize that children with congenital heart disease are now living longer because of the numerous medical and surgical advances that have happened over the last 2 decades. And now we have more adults than children living with congenital heart disease in the United States. Nonetheless, there are about millions of these children and adults. And what has become important for all of us in the community is that chronic heart failure has become a major contributor to morbidity and mortality for these patients. The concerning thing here is that there's no standardized way to treat patients with this physiology, with this congenital heart defect, and the subsequent heart failure that they face. There are nuanced differences between children and adults with heart failure. Unlike adults that have myocardial dysfunction, children with congenital heart disease have in addition anatomic and pathophysiologic abnormalities that contribute to the development of heart failure. In this particular statement, what we are trying to highlight is the epidemiology, the pathophysiology, the treatment, evaluation, and the things that we need to do as a community to help these children and adolescents with congenital heart disease who develop heart failure. We are extremely proud to say that this is the first such statement to address this important knowledge gap, and we are excited to share this with the pediatric congenital community. In this statement, we have multiple sections. The first section that starts off talks about the epidemiology of heart failure. Then we go on to talk about the mechanisms that underlie the heart dysfunction and the heart failure that this population faces. Then we move on to the clinical evaluation of chronic heart failure in this population. Then we move on to the treatments that are available and shed light onto the important knowledge gaps that we have in this area when we are treating children and adolescents with congenital heart disease and heart failure. And then finally, we make a plea to the community to make sure that we work together along with all stakeholders so that we can improve the science for this important patient group. So let's talk about the individual sections that we've covered in this paper, and I want to highlight some of the challenges that we faced as the scientific writing group when we were writing this important statement that had important knowledge gaps. So the first thing that we tackle is we talk about the epidemiology of chronic heart failure in children and adolescents with congenital heart disease. And in doing this, we have evaluated all the studies, important studies, that have been done on this topic to date, and we present it in a tabular fashion. What becomes evident in this is that children and adolescents with congenital heart disease are increasingly becoming a population that is having and experiencing heart failure. When children and adolescents with heart failure and congenital heart disease get admitted to the hospital, they're more likely to die. They're more likely to be staying in the hospital for a longer period of time, and they utilize significantly more resources compared to adults even with heart failure. This is an important message that we want to send. I think the adult community has worked really hard over the last few decades through the American Heart Association's multiple collaborations and science advancements to turn the tide. And I think it's our turn now on the pediatric side to turn this tide. The second thing that we tackle is what are the mechanisms that underlie ventricular dysfunction in children and adolescents with congenital heart disease who experience heart failure. They not only have unique anatomic and physiologic characteristics specific to their congenital heart disease, but they have undergone multiple operations. And so they have had the effect of multiple attempts of cardiopulmonary bypass, low cardiac output syndromes, oxidative stress. And I think that's why this population is so unique and vulnerable to developing heart failure. And the third section in the statement then talks about how do we define heart failure in congenital heart disease. This was an area that was fairly contentious when we were trying to write the statement because there are no unified norms, unlike we have for adults with heart failure, where you have classifications of heart failure with reduced ejection fraction, or HFrEF, and heart failure with preserved ejection fraction, or HFpEF. We tried to use some of these adult terminologies for the first time, and we were trying to translate that into pediatric patients, specifically those with congenital heart disease. And I think we've relayed the message that if we are to make a dent and move the science forward, we need to be unified in how we say things, how we define things. I think it's extremely important that as a community we have unified norms and definitions for what we call heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, because patients with congenital heart disease have both HFrEF and HFpEF, and I think it's up to us to define that. So we've tried to do that in this paper. The next section that we move on to is we talk about how do we assess heart failure severity in children and adolescents with congenital heart disease. And I think this is important because to date, in the adult world, we use the New York Heart Association classification to stage the functional limitations for adults with heart failure. On the pediatric side, we have the Ross classification, but that has not been universally accepted. And specifically as we're designing clinical trials that are looking at defined endpoints, it is important that we have unified definitions and unified mechanisms in which we define the stages of heart failure. And we've tried to do that. In addition to just looking at Ross or NYHA classification, we've added in circulating biomarkers, the importance of exercise limitation, growth percentiles, the number of heart failure hospitalizations to give a more comprehensive and sensitive method to grade heart failure severity. And a patient does not need to meet all the indications to get a particular stage of heart failure. If they get even one of these stages, they are considered to be in that stage of heart failure. We want this to be sensitive, but we want this to be in a way that's universally applicable and accepted by the community. In the next section, we talk about the various management strategies for children and adolescents with heart failure. What do you do when you have such children in front of you? We have recognized the pain point in our community. We have paucity of data in a randomized clinical fashion that defines what is good for our patients with heart failure and congenital heart disease. There are very few randomized trials in pediatric congenital heart disease and heart failure. And so we are addressing the other comorbidities that can worsen heart failure in this cohort. We are talking about management of arrhythmias, the effects of chronic cyanosis, the effects of pulmonary hypertension. And so I think it's important to understand that children and adolescents with congenital heart disease and heart failure have other comorbidities that worsen heart failure in this cohort. And then we move on to the medications. We know that there is limited data, but in this manuscript, we've tried to highlight all the studies to date using medications and highlighting where the significant knowledge gaps lie. So we talk about the RAS inhibitors, or the mineralocorticoid receptor antagonists, the beta blockers. We talk about the use of digoxin, the use of SGLT2 inhibitors, soluble guanylyl cyclase inhibitors. So we talk about all the literature that is available to us, and I think from a mechanistic perspective, try to make a case for which medications may be useful in this cohort. And then we move on to sort of the rhythm therapy. As we all know, children and adolescents with congenital heart disease and heart failure, once they have arrhythmias, whether it's bradyarrhythmias or tachyarrhythmias, or they have heart blocks, or they have other issues, it can subsequently worsen heart failure. So what do we do with that? And I think we've touched upon that to some degree in this particular statement. The last two sections are, I think, in my opinion, as a heart function, as a heart failure doc, extremely important. I think the first thing we talk about is the therapies once you have advanced heart failure. Once we try the variety of medications that we have available with limited evidence, what do we do when they have advanced heart failure? So we talk about the use of ventricular assist device, the use of heart transplantation, recognizing that there are challenges. Even to date, we have limited referrals for these children and adolescents with congenital heart disease who have advanced heart failure. I think it is concerning because we know the sicker they come into a heart transplant, the worse their outcomes are going to be, both after a VAC and after a heart transplant. So I think it is our responsibility as a community to identify heart failure early so that they can be referred to a specialist so that they can have the best outcomes that they can. And then in the final section, in the conclusion section, we try to sort of highlight the different stages of heart failure from stages A through D, and identify the therapies, albeit limited, and try to share with the community what can be done as they're moving through these stages of heart failure, and also provide an algorithm for follow-up. What kind of testing can we do? What kind of blood test can we do? When do you get an echocardiogram? When do you get a cardiac cath? When do you get hemodynamics? And I think that is laid out per stage so that our clinicians can then use it in their clinical setting. And then ultimately, I think the most important aspect of this particular statement is that it is my sincere plea to everyone in the community that I think if we are going to make a dent and improve the lives of children and adolescents with congenital heart disease and heart failure, we will have to work together. We cannot work in silos. If we are going to improve the lives of these patients, the scientists, the stakeholders, the funding agencies, the patients, the parents, all have to work together to make sure that we are doing what is best for our patients, which is these patients, these children, and these adolescents with congenital heart disease. I hope you have a great time reading the statement, and I look forward to the discussion that gets initiated once the statement gets released. Thank you.